Let's go ahead and get started. So thank you guys all for coming today. My name is Leah Botkin, and I'm the webinar officer for the Health Services Research Networking Group. Our speaker today is Dr. Jason Falvey, speaking on mobility justice, recovery and resilience after acute hospitalization. Before we get started with the presentation, I do want to advise that this meeting is being recorded. I'd like to ask all attendees to keep your phones or mics muted and keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. If you have questions, please type them in the chat feature and we will address as many of those as we can get to at the end. And with that, our speaker, you can go ahead and start sharing your own slides.
Okay, I will do that. I will set up the slideshow here and I will get shared with you guys.
Great. So Dr. Falvey is a physical therapist and clinician scientist who focuses his research on equitably improving functional and social outcomes for older adults recovering from traumatic injuries or serious illnesses. He is currently an assistant professor of physical therapy and rehabilitation science and of epidemiology and public health at the University of Maryland School of Medicine. He also serves as the inaugural director of the Center for Disability Justice. Several of his over 80 peer-reviewed publications have been featured in high-impact journals such as JAMA and Turtle Medicine. He has also received several awards for his research and leadership from the American Physical Therapy Association and American Geriatric Society. Additionally, Dr. Falvey is a board-certified clinical specialist in geriatric physical therapy and still maintains an active clinical practice at the Baltimore Veterans Administration Hospital. With that, I'll pass it over to you.
Okay. All right. Can you guys hopefully hear me still okay with the slides up? I can't see as much going on, but I'll pay attention to the chat. But thanks for coming to the talk and thanks for such a great introduction there, Leah. I'll just quickly, highlight no disclosures and have been privileged to have a lot of active funding that supports various aspects of this work. You guys have the objectives, so I won't go through those. And I just want to acknowledge up front, I have a great lab team that I work with as part of our center and part of my Enrich lab, across the spectrum from biostatistical methods to qualitative methods and everything in between, and a great K Award mentorship team. So I want to just start with the overpinning of this idea of mobility justice. And we think of this in our group as, ensuring that individuals feel safe and have the freedom to move freely in their home and communities, regardless of their identity or disability status. I think that's, important now more than ever in terms of, the factors that limit mobility can be physical, but they can also be, psychosocial. They can be, fear of crime and safety, or, perhaps fear of being accused of a crime and, not being safe in their neighborhood. So I do think mobility justice has a lot of components. And I think it's important across the spectrum of populations, though I'm going to focus on older adults because that's where most of my individual research lies. And as a brief background, as I was mentioning before, I'm from the state of Maine, where this white X is, almost part of Canada. And I identify as a first-generation college student from a rural and very low socioeconomic status background, which, kind of formative experiences for what I ended up doing in Wyoming and Colorado as a home care physical therapist, working with people with various levels of disability, and especially with Medicaid, Medicare dual eligible populations like this lady, who was one of my favorite patients, the first patient in Wyoming to be released under the incentives to remove people from long-term care and provide home and community-based care for people with disabilities in the community. She was able to come home and hang out with her dog, and I had the privilege of working with her off and on for years. And I wore suit jackets even back in 2012. So I guess that was just part of my brand. I did my PhD at the University of Colorado and then postdoc at Yale, all focused on how do we use data and move it into action, both from a health services and clinical data set perspective, all the way through an epidemiological and policy perspective that I worked on at Yale. And a lot of the formative experiences I've had as a researcher and scholar have also been driven by my dad, who is, a unique case study for policy and clinical practice by himself as a primary wheelchair user with a pathological hip fracture. He's a dual Medicare, Medicaid eligible patient who draws Social Security disability, lives in a mobile home, frequent falls because he's, has some mobility issues, and also is not a great patient. And he knows that I say this about him. And he has 2 children that he cares for, and he also cares for a spouse living with multiple sclerosis, and she intermittently cares for him. So he's a sandwich generation caregiver in some ways as well, which is very interesting. And very relevant to what what his challenges are is this concept of resilience. Like when people are facing a myriad of challenges, conceptually, we kind of think about that as resilience. How resilient is somebody to declining in function? Important for us as therapists, and how do we maintain maximal function across the continuum of care after an injury or new illness? And so resilience from the NIA's perspective has this cognitive, a psychosocial, and a physical component, but kind of underappreciated is the exposome, or the neighborhood and social environments people live in. And that can include things like social connections. It can include things like noise or pollution or access to transportation or chronic exposure to stressors like racism, like, poverty, that increase allostatic load and put stress on a system and make resilience decrease. And these aren't just psychological influences. Social isolation, for example, has a lot of biological underpinnings. So when you're removed from community and socialization, it can increase inflammation, and it can increase gene expression that makes people more susceptible to infection and with a higher inflammatory burden. So it goes way beyond just what people would consider like a soft outcome of quality of life, but there is hard biological evidence that getting people out in the community and reintegrating and socializing after some sort of event helps address resilience. And where people live also even directly impacts their brain health. So there's been brain bank studies that have linked to area deprivation index and found that people who live in the most deprived 20% of neighborhoods have more than double the odds of having ADRD neuropathological features on autopsy. So why do I care about all of this? And I care about this concept a lot because older adults, like after some sort of serious illness or injury, they want to age in place, but they also want to do that while they're engaging with the community. So often aging in place is kind of framed as you're alive and at home instead of a nursing home or other facility. But I also have to think that most of our patients want unrestricted participation in social activities. They don't want to be just home and homebound. So we often think about this high quality aging in place as a major goal for many of our studies. This is very aligned with treatment preferences for older adults from a classic New England Journal of Medicine study. When older adults, have a hypothetical, life-threatening illness, and then they're offered a life-saving treatment as part of a trade-off experiment that has low burden, like they're not going to have any functional or cognitive loss, not surprisingly, 99% of people would take the treatment in that scenario. But if the balance was shifted and that treatment then came with the trade-off of a loss of ADL independence, so older adults could take a life-saving treatment that would make them functionally dependent, only 25.6% of older adults actually accept the treatment. So that suggests that older adults prioritize function and quality of life over an extended lifespan in most cases. And this really upset the paradigm in 2002 of like what we should be prioritizing during recovery, whether it's just treatments that extend mortality or extend lifespan. And really made us think about function-focused care, which has now become a standard in many healthcare settings, and even is embedded within age-friendly care initiatives that are now policy for Medicare. So among the things that older adults really want to be able to do is walk in the community. So I took this picture of a print when I was in Italy recently, and I just thought it was like very reflective of what, people want as they get older. Companionship, to be able to be independent outside, no matter the neighborhood hazards that they might live in. They want to be able to get around their homes and communities. So community mobility to me is a marker of high quality aging in place and a marker of resilience. We often think about community mobility in terms of life space, and are people getting outside of their home environment and into their neighborhood town, or being able to get on an airplane? So delineated as non-community and community level mobility, respectively. And this jives with what older adults really want. In national survey data, generally older adults' favorite activities are things like walking and jogging, or outdoor maintenance, or playing sports. They're not mahjong and knitting like many of the ageist tropes that we might see on television or in the media. Older adults want to be active and outside of their homes. But concerningly, work from our group and others have suggested that the epidemiology of community mobility is not improving a lot over the past 2 decades. 17% of older adults, even back as early as 2004 and in 2010 with some repeat data, can't walk 2 or 3 blocks outside. 20 to 30% can't do this without a device. And 10% of older adults can't do this a year later. They were able to 1 year. 10% of older adults lose the ability to walk 3 or more blocks outside a year later. And when that happens, there's significant increases in mortality and hospitalization rates, and then impacts on other things like being able to attend church or religious services, medical appointments, or even access important transportation services. The ability to walk in the community is not equal either. There's a lot of structural issues. So this is work that we're almost finished with in the National Health and Aging Trend Study, looking at trends in weighted prevalence of ability to walk 3 blocks in the community, stratified by racial and ethnic identity. And as you can see, it's been pretty flat over the past 7 or 8 years, but it's actually declined significantly for Hispanic populations, and significant disparities by race are observed that have, in many cases worsened over time. So there's so much inequity in how people can get around in the community, and much of that is due to how minoritized patients are segregated into communities. And if you live in an economically deprived neighborhood that often is a much higher percentage of minoritized race and ethnic older adults, you're going to spend more of your remaining time alive with a disability. So even after accounting for comorbidities and other things that lead to disability, people that live in disadvantaged areas in these light blue bars spend a much higher percentage of their remaining life with a disability. So active versus disabled life expectancy is a major issue. And for older adults in these economically deprived neighborhoods, they often just aren't able to be functionally independent for as long. So we've followed up on some of this. So our lab tends to do a lot of mixed methods work, taking what we've learned from data and projects that I was involved in, like this one as a co-author with Tom Gill at Yale. And then we did some qualitative work in West Baltimore in these highly deprived neighborhoods to get an idea of why mobility recovery is so challenging. And what we found was across these 5 themes, which we presented at a couple of other conferences, and the manuscripts in preparation here, is things like, pain and mental physical exhaustion limit mobility, but also things like neighborhood built environment and crime are big deterrents. And we don't normally address any outdoor mobility challenges that people have in our traditional rehabilitation paradigms. Home care therapists don't do it because they don't want the patient to not be considered homebound. Outpatient therapists don't do it because they often have multiple patients in the gym at the same time, and it may not be, financially viable to take patients outside and one-on-one treatments and practice things like getting up, on a bus, or being able to practice walking to a bus stop over uneven, broken sidewalks. So a lot of addressable concerns that people have raised that we've started to record for, a future intervention trial. And we've come up with, what we think are 5 major themes that drive, impaired community mobility and inequities in community mobility across our groups that we've been studying. And those are transit access, neighborhood SES, social cohesion, built environment, and neighborhood safety. So if we think about social cohesion to start, that's in general the sense of solidarity, between members of a community. We'd want our communities to be, open and thriving spaces where socialization across generations is happening, but that's definitely not happening routinely, and much less so in lower income areas. And if you live in one of these areas with low social cohesion, when people aren't out and collaborating with each other, not surprisingly, you're less likely to go out and visit with your family and friends, and that increases your social isolation risk. So when you're not living in a neighborhood that fosters social cohesion and fosters social relationships, it makes you more likely to be socially isolated, which has some pretty significant health consequences. And, some of those lacking in social supports are really, it really magnifies after some sort of new illness or injury. So you end up in the hospital or end up with a hip fracture. And we realize how little the caregiving network can support that patient, how they have limited transportation options if no one can bring them to appointments. And it rapidly can erode cognitive health. And that's concerning because 1 in 4 older adults at baseline are socially isolated. So when I was at Yale, we actually took a look at how social isolation impacts recovery from a catastrophically disabling hospitalization among critical illness survivors, and basically looked at people who are socially isolated before their hospitalization, and to look and see how mortality and disability were impacted over the subsequent year. And what we found was a pretty significant dose-dependent effect of social isolation on mortality. So from 0 being the least isolated to 6 being the most isolated, you can see, like, with every increasing amount of social isolation based on a validated metric, there was a higher probability of mortality, which ended up being more than double the risk, 119% increase in the risk between the most and least socially isolated groups, but pretty clean relationships between each level. We saw similar relationships for functional impairment. So as social isolation increased, the gap between pre-ICU and post-ICU functioning increased and resulted in a higher mean number of disabilities. And while a difference between 1 and 3 ADL disabilities might not sound like much, those are needing human assistance with additional, tasks like bathing, dressing, walking inside. So it can represent a pretty high escalation in caregiver burden. So some of what we've thought about is, like, to really make mobility more equitable is we have to think about it at the community level. How do we help foster connections in the community to buffer effects of hospitalization and reduce these life-based mobility declines, like reducing the impact on mobility disability? When we've asked our patients in our qualitative work, they've said things like, when we've asked about would your community help you if they saw you in trouble outside of your house, what would they do? And this person was like, yeah, they would, like little things. If my shoe was untied, they come and tie it for me and stuff like that. They make sure I don't trip, because that's happened. If I need a little help coming in the house, if I have too many bags, they're very helpful. I live in a big building with a lot of people, so someone is always there to help. This person clearly feels comfortable taking risks and going outside their home because they have a lot of support. You'll see that that's not the case in some of our other interview comments that we'll have. Another major aspect that hangs out with social cohesion is transit access, especially for people who are non-drivers. And one major thing to consider is in urban areas like Baltimore, where I am, 10% of older adults are regular users of public transportation. And 600,000 across the US actually use public transit as the primary way to see their doctor. And this is work that was led by a medical student here that out of our group that was our research assistant before she went to medical school. And it was kind of interesting to see. And one other finding that we had was things like in the neighborhood, broken and cracked sidewalks near the home were major deterrents for public transportation use. And people that couldn't walk 3 or more blocks often couldn't access public transportation. So these were really major findings that kind of support the importance of community mobility and some of the contextual barriers that might limit equitable access to that. And in some other city areas, so Philippa Clark did this work in Chicago, 20% of older adults have to walk more than 500 meters to access fixed route transit, so 1,500 feet. And the distances are longer generally in the lower economic status neighborhoods. More economically deprived neighborhoods have less transit density, even though more people rely on transit. So it's a really big mismatch that has some relatively high health consequences. But simple things at the community level can improve this, like subsidizing public transit, making it low cost or free. In some prior studies shows that people are more likely to use it and also be more physically active because they're walking to the stops. And can reduce depressive symptoms, and the hypothesis is through better social connectedness. When older adults live in areas with higher transit density, they're walking more for exercise, and that's more likely due to, more investment at the neighborhood level and structural advantages to promote physical activity. So another piece of advocacy that we can be part of that maybe is tangential in your mind to PT, but we're finding that there is so much connection between access to transportation and participation in healthy behaviors. And communities can make small decisions with outsized impacts on these rates. The one community member say they have bus depots where we could sit with shelter and wait for buses and whatnot. But then people started sleeping in them. They removed them a lot. And now in my area, there's none. So for me and no bus bench is kind of an inconvenience if we're waiting 15 or 20 minutes for a bus. But for an older adult with heart failure or dyspnea or with back pain with ambulation, this could be the difference between being able to use the bus and not, if there's nowhere to sit at the stop or no shelter for somebody who might have chronic health conditions and not do well with being exposed to the elements. So like we've hinted at, the built environment itself has a lot of associations with how people move. These open spaces, green spaces, buildings and sidewalks, and ChatGPT's depiction of what walking over a sidewalk in Baltimore might look like if I asked it to exaggerate a little. And sadly, this might not be exaggerating in some neighborhoods. This is an actual photo of Baltimore. And not surprisingly, if you live in an area like this nationally, you're 4.5 times more likely to report a mobility disability or being unable to walk 2 or 3 blocks. And things like this were a major reason why Baltimore was the target of a major lawsuit by people living with disabilities who couldn't access much of the necessary infrastructure with power wheelchairs. Living in a neighborhood like this also is associated with much higher odds of being a recurrent faller in national survey data. When we ask patients about the challenges with living in areas that are not well set up for mobility, they'll say things like, I don't like crossing a bunch of streets. Maybe 3 or 4 years ago, I would cross Martin Luther King Boulevard, which is a major north-south thoroughfare in Baltimore. That one side is where many people live, and the other side is where all the healthcare is. And this person's saying they wouldn't cross Martin Luther King if their life depended on it. There's too much going on. They drive like bats out of hell. They drive like they're on the highways. I'll be scared. I'm scared half to death to go across Martin Luther King. Okay? Inconvenience for many of us, but for them, it's the only conduit to being able to access healthcare or transportation, to walk across that street and be able to catch convenient buses. So a lot of that is the light timing, and the structure of the sidewalks don't allow for people to feel safe using mobility devices to cross major streets. And other people have talked specifically about the built environment and the uneven pavement that has contributed to long-term musculoskeletal injuries. Much of this can be attributed back, if we look at root causes, to neighborhood socioeconomic status. How much is the community or the government, the city or the state investing in the neighborhood infrastructure? And when they invest less, there's less access to medical care, green space, less access to infrastructure like lighting or appropriate curbs and curb cutouts. This isn't just a physical manifestation. It doesn't just result in limited mobility, but it also has an impact on cognition. So there's this concept of cognability, where what's invested in at the neighborhood level in terms of senior centers and museums and libraries and more parks is associated with higher cognitive function. And in neighborhoods that have more highways and polluting sites, which make mobility typically less convenient, are associated with worse cognitive function. So there's now, that's mapped. Every zip code has a cognability score, which I think is a widely underutilized resource for trying to think about what impacts our patients' recovery after disabling events. We often measure neighborhood SES in this area deprivation index. So we use this 9-digit zip code or census block group linked index that gives us a really good sense of what the economic status looks like in a neighborhood. And as you can see, I live in Baltimore, where our medical campus is in the gray square right next to the B to the left. And then everything in West Baltimore, where I do all of my research, is pretty much in the highest level of socioeconomic deprivation. I happen to live in one of the neighborhoods right adjacent to this as well, and can see it firsthand. When you live in neighborhoods like this, prior work that our group has done in Connecticut has found that the most disadvantaged, people that live in the most disadvantaged census block groups have higher levels of disability that persist over 12 months after discharge from a critical illness. And that's even after accounting for frailty and cognitive status and comorbidities. And it ends up being 10 to 15% higher level of disability burden over a year. When we look at work that we've done with COVID-19 survivorship, symptom burden across from baseline hospital admission all the way through 6 months is highest in areas with the highest deprivation index, even after accounting for important comorbidities. So that's another piece of work that we're putting through the review process that kind of highlights this impact of neighborhood. We've done work with emergency general surgery, which is not necessarily a rehab condition, but these patients have high levels of disability after an emergency gallbladder surgery or an emergency surgery for diverticulitis or something like that. And when people live in highly deprived neighborhoods and have a high geriatric vulnerability, there's actually multiplicative, increases in mortality risk, from 6 times the risk for the high geriatric vulnerability patients in more advantaged areas And that risk goes up to 15 times higher risk for 1-year mortality in the most high poverty neighborhoods. So there's a lot of evidence that neighborhoods magnify the impact of other, risk factors that we know are associated with poor outcomes after some sort of debilitating injury or illness. We have done a lot of work in our claims data, and I would say we have 20 papers that are either published or in process here with neighborhood deprivation and patient-centered outcomes. So in this case, we've built the file around hip fracture, which is my K award topic, geriatric trauma, and we have looked at this idea of days at home, which we basically can calculate putting all the claims together in addition to the MDS files and know how many days somebody spent at home versus in an institution every month after they were hospitalized for something. And we're able to account for the probability of mortality in each fracture month and really estimate what people's likelihood of being at home across a year following hip fracture is based on their neighborhood area deprivation index. And what we found is when we stratify people into the poorest 10%, the wealthiest 10%, and the middle 80%, which is a common way to look at thresholds of poverty, we can see that despite being pretty similar in the month before fracture, in the year following a hip fracture, the poorest 10% of patients spend considerably less time at home. It ends up being, in our preliminary analysis was 26 more days away from home after hip fracture, and we're working on refining this paper, but it's still between 20 and 26 more days at home, which exceeds clinically important differences both from patient perspective and from other published literature. So there is an effect of neighborhood that is above and beyond the effects of other comorbidities. We saw very similar patterns in traumatic brain injury outcomes. And this work is published in the Journal of Head Trauma Rehabilitation, where the poorest 10% had considerably worse outcomes over the year following TBI. And this was any hospitalized patient for TBI, even if they didn't require extensive rehabilitation afterwards. Just any experience with head trauma, be it mild or severe, on average was associated with poor outcomes if you lived in the most highly deprived neighborhoods. Living in those neighborhoods is also associated with receiving worse quality post-acute care, so both from the skilled nursing facilities and for home health agencies. Our work that we've done with nursing home staffing has suggested that if you are receiving care in a nursing home located in a really highly disadvantaged area, there's much fewer registered nurse hours, CNA hours, and across all the rehab disciplines, there's significantly fewer hours spent, with the only equivocal staffing being a licensed practical nurses, which are usually used as a substitute for registered nurses in many facilities when there's shortages. We also found that quality metrics related to nursing homes are much worse when you're in highly deprived neighborhoods. So prevalence of antipsychotics being given to patients in nursing homes is much higher if those nursing homes are located in highly deprived neighborhoods. And that's only slightly mitigated by better nurse staffing, but there's still differences even at the most highly staffed nursing homes. There is still a small difference in antipsychotic prescribing. So when we ask patients about what the community or socioeconomic status of their community actually does in terms of impact, they say things like the community's no help because all the carrying on going around here. The store that's close to me has closed. I'm looking at a store that's even further away I have to get to. So yeah, what's happening in the community is definitely affecting my surgery and my recovery to an extent. So something as simple as economic investment in a neighborhood that maybe leads to a store closure. This might be 3 blocks away and just at the max of this person's distance, and then the next closest store opens 3 more blocks away. And then all of a sudden, a primary source of food is no longer available. And that's pretty common in some of these deeper urban areas where car ownership is low and public transit's very inefficient. So I'm going to skip over the neighborhood safety for time, but just know we are seeing a lot of effects of crime on neighborhood and community mobility as well, both from in the perspectives of our patients and others. So what I want you to come away with is that we use a wide variety of methods, both from survey data, from qualitative data, and claims data, to really look at where somebody lives and how that impacts their functional decline and functional recovery, and how do we make this more equitable. And obviously what we're learning in our qualitative work is some impacts are very measurable and some aren't. So we really have to think about creative ways to bring in other data or more local community data to answer some of these questions. And what I might leave you with, and then we can have some extended conversation about this, but I give this slide at the end of a lot of my talks where we think about, squats don't address social determinants of health. I say this to PT audiences all the time, because no matter how strong you get somebody after a knee replacement or a hip fracture or some sort of debilitating hospitalization, you don't actually address some of these neighborhood contextual barriers that are really limiting mobility. So you're not going to move the needle on their community mobility very much if we're only focusing on exercise. So really getting people to think about what are the actual barriers to community mobility, asking patients, and then being ready to intervene with community resources, being able to extend therapy outside of the gym into the community whenever possible, and thinking about how to address this a little bit more thoroughly. And we're taking all of the data that we have, and we have a pilot trial getting ready to start up that's actually testing a multi-component intervention that I'll just show you quickly. This is our planned multi-component intervention called iConnect, which is includes a community health worker going in and getting mobility screenings for what resources might be needed, teaching people about transportation access, and we will be paying for some community transportation, getting people new medical equipment from a statewide durable medical reuse program that's no cost to people, and then doing outdoor home modifications to improve people's ability to get out of the home and pair them up with social connections that are younger peers, which they specifically asked for in our community advisory board to allow them to give back to the community while being able to have some more social connections. So this is where we're going with all of that work, and why we're triangulating so much of the claims and the survey data and the qualitative data we're doing, and really bringing it back to the community and trying to use their voices to design meaningful interventions. So I'll leave you guys with that, because I think there's so much to unpack, and I have a lot of other things that I have to obviously present to make that a comprehensive talk. I can't do it justice in 45 minutes, but I think maybe we can start from there and see what you guys want to talk about.
Thanks, Jason. It was perfect ending, because I felt like during the presentation, I was like, okay, I'm wondering where this is building towards, and particularly the clinical impact and what policy changes might need to happen for this work to take place. So I feel like you've talked about what needs to change in clinical practice. Do you feel like there's any policy changes that need to happen to actually have this change in practice, or do you feel like it's more of a build from the clinical site type of intervention?
Yeah, so I think there are some policy changes. So I'll actually I will share the policy slide that I have, which I do have one. So this is one slide of very simple changes that we've thought about. Is from a policy side, obviously more support for safety net hospitals and safety net community providers, but one way to do that is micro-targeting. So Medicare does this with home care agencies to some extent, where agencies that serve very rural beneficiaries get an add-on payment. They get additional money added to their payment for serving really rural beneficiaries based on a zip code or county code. So there's no reason you couldn't do that for facilities in highly economically deprived census blocks and be able to support their staffing or support other efforts to bring in more money to make sure they don't close and make sure that they're able to provide all the care that somebody would need. So that is something we've advocated for across a lot of policy sources. And even something simple like Medicare right now does not allow you to give somebody durable medical equipment if they only need it to walk outside. They have to need it for inside of their house. So a lot of people don't get rollators because they can't use it in the house, or they tell their doctor they're not intending to use it in the house, that they only would need it to walk outside. So, and that often will limit, that documentation carries through sometimes, and then it limits somebody from being able to get one. And while you can buy it out of pocket, they're not cheap. So the people that can buy it out of pocket are often the people who have a lot of ways to get around in the community, not just this one. So I would say those are two policy things. The other is Medicare, is requiring some screening of social determinants of health during hospital and rehab stays. And I think we could do that in a way that's a checkbox where you actually just do it and check the box off in the EMR so it stops yelling at you. Or you can do it where you have you use neighborhood as one of those things that you're screening for as part of the social isolation or food insecurity or financial strain. And then you have meaningful connections with community organizations that you get set up before that person leaves. And that's, another way I think you could take a policy that exists, and if you build your compliance with that around something meaningful, then you could actually improve outcomes. That's a take that our medical student that is working on our hip fracture ADI paper, she's really feels strongly that they don't do a good job screening and PM&R, on meaningful things, and they're trying to make it a lot more action oriented versus just check the box that you screen this.
Interesting. Yeah, because I guess, sorry, and if anyone else has any questions, because I feel like who do you foresee that being a community, like someone from the community's role, in the hospital or the outpatient setting, or the therapist role, or the social workers? Because I feel like in the acute care setting, it's there's so many different people that are kind of addressing all of those social determinants of health. Do you foresee it still being a slightly fragmented approach, or do you think there's one individual that maybe would be able to kind of harness all of those disciplines and then provide the resources that are needed? And then maybe even someone that could follow them throughout their continuum of care.
Yeah, so that is a really interesting question. One of the reasons we have a community health worker in our study, we had planned on using social workers, PTs, nurses, and all doing separate components. And our community advisory board members were all very strong. We just need one person to contact. We have so many people, we can't ever get a hold of the doctor or the nurse or the therapist, or I saw this therapist once and then I saw a different therapist. And so we're actually piloting out our intervention that is centered around a community health worker. And there's a lot of models like this in Europe, which are called, for hip fracture, for example, they use this fracture liaison service. So a fracture liaison, somebody follows them across the continuum of care, checks in at each care setting and makes sure that things like home modifications or equipment are gotten, make sure that that person has a follow-up appointment for bone modifying medications and they're on evidence-based routine, or they know how to implement that person can assist with management of other medical appointments and helping just kind of be the quarterback. So we run a clinic like this in the VA too, where our job is as balance and mobility clinic is literally just working with medically complex older adults in geriatric service and having geriatricians and PT with that person, and then managing all of their functional care needs, and not in an episodic way, but we hold them long term. So I think a fracture liaison service, if the hospital paid for something like that, and whether or not it was tailored towards higher risk people with social determinants of health that, met a certain level, and then they had this fracture liaison service that followed them across the continuum and helped them connect with community resources or transportation or other things, I think that could be really high value. And it's something we've really thought about testing for trauma survivors, because we work from a major trauma center across the street. Geriatric trauma is becoming much more common. So we're thinking that we could support them with that and test out a model like that.
Excellent. It feels unsurprising that Europe already has something like that in place compared to that I guess they have like smaller health systems than us, like on a lot of accounts, I guess, maybe some, but interesting.
Yeah, and having a single payer often helps because there's more motivation for people to work together. Here, we often don't have that because the hospitals are kind of like, once you're out, they want to get you out 30 days and then, they're good. Home care and skilled nursing facilities and outpatient don't often talk to each other. And there's not much incentive for them to do that. And sometimes there's a disincentive because you don't get paid. So there are some billing codes that are being created for like transitional care service or liaison type of services for fracture that are being created by AMA. So we'll see if those help at all. There are other questions? I know that was a lot to unpack and I was trying to move through so we could have some chance to chat, but yeah, I'm happy to hang out until 2 if people have other questions.
Where you are, for patients that are like dual enrollment Medicare, Medicaid, are there, like in Wisconsin, we have something called IRIS where they can apply for this program and get funding for some of the concerns that you brought up that are not directly medical. It might be home modifications, it might be caregivers, like the patient can kind of direct some of those funds where they find it most needed. Is that something that is offered in your state, or is that more state specific?
Yeah, so I know Maryland has some like HCBS waiver services that are flexible. I don't think to the extent that they can choose as flexibly as Wisconsin can. There is some of that. I think some of the problem with that is that puts a lot of the responsibility still on the patient. And the patient, they have these resources. They don't know who to call, how to advocate. They don't know what to ask for. Sometimes if there's a resource you don't even know exists, you don't know to ask for it. So I think it's helpful. I think, that came out of the Affordable Care Act where people could take their long-term care dollars and instead be able to, instead of being in a facility, could use it for services and supports in the community. But I think it's very fragmented for one. And two, I think it's not rapid enough for somebody that has a fracture or a new injury or illness. We have sometimes a 3 to 6 month window to stabilize them being able to age in place, or they either end up in an escalated amount of care or caregiving burden's higher, move to assisted living, or end up in a nursing home. And after hip fracture, especially for dementia, which is a population we focus on, with some of our other types of data work, it just, you basically have 6 months to make a difference, or you probably lost that opportunity. So I think being able to do it rapidly is kind of the key here.
Absolutely. It can take more than 6 months to even get approved for those services.
Yep. I mean, I have a patient with ALS in the VA, which is the very best place to have ALS if there's a good place. And it's still taken months to get home modifications and things approved through, like, in a system where they've done it a lot and they know exactly how it works. It's just very challenging to get all the vendors and all the signatures on things. So.
Thank you so much for sharing with us today.
problem. I'm hoping there's something to take back. I know it was kind of health servicey / maybe a little off the beaten path from what you guys might see with big data, but I think it's nice to have that comprehensive kind of multi-method approach, I hope.
Absolutely. And Jason, I was just curious because you said you use a combination of different data. What are all the data sources you're using? You said NHATS, I heard.
Yep. So I use National Health and Aging Trend Study data. We use we have a lot of CMS data. So I have like a 20% random sample of CMS data, which we use, and we have the 9-digit zip code linkages, which we specially requested. So we can do ADI linkages, and we have a lot of people doing clinical work with that, as well as biostatistical like methods development for understanding how to predict these days at home outcomes or look at prediction model equity and a lot of other things. And then we use we have some other cohort studies. So like at Yale, there's a cohort study that we used called the Precipitating Event Study. It's been going on since 1999, and they do monthly assessments of disability by phone. And then every 18 months, they do like a comprehensive physical performance assessment. And they started with like 700 and something people in 1999 and still have some people alive that they're following longitudinally. So they are able to do a lot of like the trajectory timing of disability and things in a regional cohort. And then we've replicated some of that structure with our days at home in a national cohort. So.
Oh, interesting.
Yeah, so definitely happy if people have questions about those data. CMS is obviously a little harder to get your hands on, but NHATS is fully public, and we've just put together all the survey years, cleaned it up, and so we have kind of a public version that very few people look at rehab specific questions in NHATS, but there's a lot of rich data there that we've started to look at. My PhD students doing some work with pulmonary disability and rehab use, and we're doing a lot of work from community mobility. We're looking at rehab use and like just home environments and like how challenging the home environments are getting over time for people getting home-based therapy. So. So, all right, Leah, I saw you pop on, so it's probably time for us to transition.
You're fine. You've got 2 more minutes if anybody else has any questions.
Okay.
But thank you again, and I appreciate the questions so far and the information. It's been really interesting.
Yeah, thank you so much for your time and the presentation, Jason.
Yeah, no, I'm glad we could present here, and glad some of that was useful. And again, happy to follow up if there is something that struck you that you're like, oh, I would love to partner or collaborate, or if you have students or trainees that are interested in any of these questions. We try to be collaborative. We have a good team. We're knock on wood, reasonably well funded at this point. Hopefully not at risk for losing any of that federal funding in the near foreseeable future. But I think we also have some investment in the state level at our Center for Disability Justice. So we have some funding that we can continue some of these initiatives. Great. Okay. Well, thank you all for taking an hour out of your day, and look forward to connecting in the future.
Thank you, Jason.
Okay,
Thanks,
bye.
Jason. Have a good one.